Okay, so right now we're in chapter 14 on liver disease. And right now we're on page 37, but I would like you to look up at table 8 on page 29. It's a table comparing the different types of viruses that cause hepatitis, and I think it'll tie together stuff you're learning in microbiology and immunology. So look at table 8 on page 29. Then you can scroll down here to page 37, starting with clinical manifestations of acute viral hepatitis, the prodrome and the ecteric phase. Um, this figure 11, about different serologies between the different viruses, you'll see over and over, and it's typically on boards and that kind of thing. So look at that. Other manifestations: jaundice, changes in stool color and urine color, bruising, abnormalities in the liver enzymes, and then serologies. This table 11, serologies of hepatitis B. This is also classically tested, and you'll need to know this up and down, and we'll certainly be going over it in class and on your exams and that kind of thing. So look at that. Encephalopathy, mental status changes, renal dysfunction, and then entering the convalescent phase. So acute hepatitis typically lasts a few months. If it lasts longer than 6 months, it is defined as chronic hepatitis. So chronic hepatitis here, you don't have to worry about the staging system. Clinical presentation, nonspecific symptoms, and then look here at extrahepatic manifestations of chronic viral hepatitis. Hepatitis C, you classically will see test questions on cryoglobulinemia, glomerulonephritis. For Hep B, I feel like PAN, polyarteritis nodosa, and glomerulonephritis tend to be on tests, but you will see these. Etiology of chronic hepatitis: viruses, drugs, including alcohol and Tylenol, genetic disorders, and then pathogenesis. A lot of it is thought to be immune mediated. You don't have to worry about these drugs. And then chronic viral hepatitis, here's a little detail on that, detail on alcoholic chronic hepatitis. You don't have to worry about this figure unless it helps you in pathology. Do read about non-alcoholic fatty liver disease. It's super common. It's associated with metabolic syndrome, which we'll learn about in this block as well. And it can be completely asymptomatic, or it can progress to cirrhosis. And so the two kind of different types are non-alcoholic fatty liver and then NASH. So non-alcoholic fatty liver is benign with minimal inflammation, and then NASH is more active inflammation, and there is a risk for cirrhosis and even hepatocellular carcinoma. The pathogenesis, I believe you learn about this some in biochemistry. You don't have to know the details for us. And then other types of chronic hepatitis, autoimmune hepatitis, you do hear about that and is tested. You don't have to worry about this pathology image. Then there are cholestatic forms of liver disease. So PBC and PSC are two types, and PSC is associated with inflammatory bowel disease. So you'll also be learning about that later in the block. Clinical manifestations of chronic hepatitis can be asymptomatic, can have nonspecific symptoms. But note that by definition, with chronic hepatitis, signs of cirrhosis and portal hypertension are absent. Because if those were present, then it would be cirrhosis, not chronic hepatitis. Okay, moving on to cirrhosis. So the clinical presentation, this figure is good, figure 15. It breaks down the different findings into being a result of the hepatocyte cell death or being a result of portal hypertension. So look at this. Pathogenesis, the first two paragraphs here, you can read through, please. You don't have to worry about these figures, this stuff. There's a lot of detail here. Clinical manifestations, the figure 15 from above, and then here's some explanation of all of those. And here it is kind of in table form. So manifestations due to portal hypertension and manifestations due to hepatocyte cell death, and then other complications. And then these are all kind of like explained down here in the text. So portal hypertension, ascites, especially this first paragraph, including the SAG, you need to know that. Figure 17, proposed mechanism for how ascites develops. And we will be talking more about this with physiology as well. Hepatorenal syndrome, super interesting. So this first paragraph is important. You don't have to know the other details. You don't have to worry about this. And really it's this first paragraph that's important. Edema, low albumin, read these 3 paragraphs. SBP is when the ascites fluid becomes spontaneously infected. So this first paragraph is important, and you will see it on the floor. I would point out these predisposing factors. So patients who have really large ascites, very low protein in the ascites, a history of SBP, or if they have an upper GI bleed, they're at increased risk of getting SBP, and we even sometimes prophylax those patients with antibiotics to prevent it. Varices and bleeding, encephalopathy, including the physical exam manifestation of encephalopathy called asterixis. Recall that, know that encephalopathy usually has some sort of precipitant, whether it's a GI bleed or infection or medications. There's typically something that precipitates the event. Coagulopathy, splenomegaly, and hypersplenism, and HCC. So there are pulmonary complications. So I would just focus on this first paragraph here. And then I feel like we didn't, maybe I missed it. We'll come back. And then miscellaneous manifestations, spider angiomata, gynecomastia, and contractures. And I just want to make sure we got hepatorenal syndrome. Where is hepatorenal syndrome? So make sure you read the section on hepatorenal syndrome, okay? I'm going to scroll down and make sure I didn't miss it. And that is it. Let me know if you have questions.